Alrighty, let me just organize myself for a sec. Alrighty. Thanks, Abra. So, as Abra said, I'm going to talk about a case that happened at Rosebud. This is a picture that I got off the internet of the pier at Rosebud Beach. I'm going to start by saying I'm not actually a toxicologist. So, it is a toxicology talk, but please don't ask me complicated questions at the end because I'm not a toxicologist. But the focus of this talk is a little bit about the clinical side of how the patient presented, but mostly about how things differ when you are not in a tertiary hospital where you've got all resources at your beck and call. So I'm going to start by presenting the patient. So we've got a 56-year-old female patient, came in the later part of the afternoon, initially as a Cat 3, triaged as being confused. She was actually re-triaged about 25 minutes later to a Cat 2 because they discovered she actually had some altered conscious state. And then further details were put into the triage, such as she was found on the floor, last seen well yesterday, possible long lie, and BSL was low. So the vitals that were provided by ambulance staff on their arrival. So I'm not going to go through them in detail. You can see them there. Probably a little bit hypotensive for a 56-year-old, but otherwise not too bad. But the main thing to note is that her BSL was low and needed some glucogel to come up to normal again. And then when she came into ED, her first vitals were improved from a blood pressure perspective, except her GCS was now lower than initial. Further history. She was found by a friend in an altered conscious state when she was at home. As per ambulance notes, the home was reportedly in good condition. There was no empty packets, no bottles lying around, and no suggestion of a possible overdose, but was noted to have had a previous large ethylene glycol ingestion requiring hemodialysis in the not too distant past. These are verbatim words taken from the patient's documentation from the treating doctor, who was not actually myself. Sweet smelling breath, moist mucous membranes, palpable bladder, reflexes, tone, pupils, all kind of normal, and no evidence of incontinence or tongue biting. And I think that the examination findings were very focused and specific, and they were put in there really to let people know that they were thinking of certain toxidromes and therefore excluding them based on the examination findings. So yes, the documentation was very succinct, but it was actually quite focused on a toxicological perspective for this patient, given the known previous history. Investigations. So ECG was normal. That's the first VBG that we got. And I'm going to give you guys a few minutes to have a look through that, and then I'm going to ask for some assistance in interpreting it. So um, unmute yourselves, shout out some answers, and we're going to go through interpreting that VBG together. All right. Can I get some volunteers for starting off with an interpretation of that VBG?
I'll have a go if that's all right. My name's Ryan. I'm one of the registrars at the Austin.
Thanks, Ryan.
Yeah, and forgive me here. This is looks like a tricky one, but we've got an acidemic patient at a pH of 7.3. Bicarb is slightly low and CO2 of 41. It looks like metabolic acidosis without entire respiratory compensation, so a mixed metabolic respiratory acidosis with a high anion gap at roughly 20 something, almost 20, so about 18 or so. And that's about as far as I got so far.
All
Ionized
right.
calcium looks okay. Potassium's a bit low when you account for the acidosis.
Beautiful. That's a great start. Thank you. All right. So we do have a metabolic acidosis. Um, Bicarb is, yeah, less than 22, pH less than 7.35. So starting with the basics. So whenever we get a metabolic acidosis, what's our next step in interpreting to try and figure out exactly what's going on? Anybody else want to shout out with some further formulas that we would like to try and do now?
Lucy said anion gap.
Thank you. Lucy, do you want to explain, maybe unmute yourself and talk about an anion gap and how you'd work that out? So Ryan mentioned it's about 18 or close to 20. Can you explain exactly, Lucy, can you explain how an iron gap is calculated?
Um, I will do my best.
Thank you.
Um, it just measures the difference between cations and anions in your blood to evaluate the acidosis that this patient's kind of showing. Normally, you can just do the sodium minus the chloride plus the bicarb.
Mhm.
And in that case, it was worked out as 18, or let me just put it in my calculator. But yeah, that's how you
Yep.
normally adjust on on the VBG.
Yep.
And then you kind of go through kind of raised and not raised. So then you go through like the causes of that from that point of
Yeah.
view.
Great. Okay. So I worked it out at 17. So if my maths is wrong, please tell me. But yes, so we've got a raised anion gap or a HAGMA, high anion gap metabolic acidosis. And then we need to figure out the causes of that. And based on that gas, the likely cause is the lactate. It's one of the most common causes, but for this patient, absolutely with a lactate of 18, we're likely to be lactators causing the metabolic acidosis. You go through the differential of cat mud piles, and there's a couple of things that step out there or kind of pique our interest for this particular patient as being a cause for a lactate. All right, so we've got a HAGMA. We've mentioned the CO2. Can someone tell me how we're going to work out what the expected CO2 is for this patient with their metabolic acidosis?
Yeah, hi, this is Mo. I'm one of the registrars at Box Hill Hospital.
Thank you.
So it is the Winters formula 1.5 times the bicarb plus 8. It will be
Yep.
38 plus minus 2.
Yep.
So, yeah, yeah. There is an element of respiratory acidosis, but it is very mild because the expected the CO2 is 38 and the CO2 is 41. Uh,
Yep.
so I would say there is a very um, little of respiratory acidosis. Then we do the delta ratio. Delta ratio is the difference in anion gap divided by the difference in bicarb. And delta ratio here will be 17 minus 12, which will be 5 divided by 24 minus 20 will be 4. So it is almost 1.2.
Hmm.
Is my math correct? I'm not sure.
Perfect. Absolutely. Yep.
So yeah, so this gives the indication that it is a mixed disorder because the ratio is above 0.8. So there is an underlying metabolic alkalosis or respiratory acidosis as well.
Okay. Pretty good. I got the same 1.25. Has anyone got any advances on how to interpret that 1.25 number?
So the ratio is between 1 to 2. Uh,
I think if the ratio is between 1 to 2, it's more pointing towards high
Pure
end.
Hagma, yeah.
Correct. Yeah, so it's actually a pure Hagmar. And when you work out the winter formula, yes, we said like technically it's out by one, but it's pretty much close enough, right? And certainly for exam situations, if there is going to be a mixed disorder or a discrepancy when you work out the formulas, it's going to be a proper difference. So a difference of like two or three here or there, the winter formula when you work it out, it's actually close enough where the expected and the actual are pretty much the same. And that, yeah, with this delta ratio, when we work it out at 1.25, it actually works out to be technically a pure Hagmar, which kind of fits. So we're not going to sweat the differences with one or two here or there. But for exam purposes, if there is a difference, there'll be a proper difference, just as a little tip. All right. Thank you very much to all of those who um, were brave enough to help with that interpretation. We're going to move on to what the bloods look like. Those were the formal bloods that came back. Now, at Rosebud Hospital, depending on the time of the day, we don't always have pathology on site. Um, Probably given the time of the day and when the bloods were sent, they probably would have just snuck in to have on-site pathology. So the results, I didn't actually check how long it would have been taken to come back. But if this was overnight, for example, then it would be a delay of at least two, sometimes longer, 2 to 3 hours before getting blood results because they have to wait for an hourly courier, get them to Frankston. They always get lost at reception in Frankston. It takes them an hour to find the bloods and then they get analyzed and get results available online. But these are the blood results that came back for the patient. Having a quick look through, there's nothing really terrible. Um, Interestingly, ETOH not detected, paracetamol normal, LFT lipase, troponin all normal, so nothing terribly exciting there. So we're moving on. In the notes, the assessment of the patient. This is their diagnosis. Presumed ethylene glycol overdose given history and sweet breath and large lactate rise. And I think it's really important when we're seeing patients to come up with a differential but explain why. So why do we think that? We're trying to put things together. We're a little bit of a detective in ED. We've got some clues at our disposal, some further tests we might want to do, but try and put things together and explain yourself. Right, we've got an ethylene glycol overdose. What are we going to do about it? We don't actually have any of the first line antidotes available at Rosebud Hospital. Fomepizole, don't have it. IV ethanol, don't have it. What are we going to do?
You're
These,
close enough to a bottle shop.
exactly right. This is what the next lot of doctor notes say. Alter conscious state, presumed antifreeze overdose, lactate 18, pH 7.2, no IV ethanol available. We're going to go to the bottle shop. So literally down the road, lucky enough to have a thirsty camel. And this is what the doctor wrote. I have bought 37% ethanol from Thirsty Camel. So they literally went down the road to the bottle shop. After hours, what happens? Bottle shop's closed. We're in a bit of strife. Have a think about that, what you're going to do. Luckily, it was a evening. Bottle shop still open. We got what we needed. So nasogastric was inserted, noted to be draining some bright pink fluid. Through that nasogastric, they gave 120 mils of the vodka. Nasogastric was clamped. A few minutes later, they intubated the patient. Um, the note specifically said how much vodka was given, what the next dose is going to be, in what parameter and time frame. So really beautifully clear notes.
Um, Danielle, there's a suggestion of using hand sanitizer.
Hand sanitizer doesn't have enough alcohol content in it for most of the hand sanitizer that's available
Ah,
in hospital settings. So I don't think that's going to be helpful, unfortunately. All right. Post-intubation VBG. Somewhat similar, nothing too out of the ordinary based on the first one. Slight worsening, so slightly more acidotic, a slightly increased lactate level. Bicarb's now down to 14, so probably a little bit worse than when she first arrived. Shipped her off up to Frankston Hospital and to ED there. So, some numbers from initial blood results when the patient was now at Frankston Hospital. So there was a little bit of a delay between when the patient arrived versus getting a formal serum lactate level. So there was a little bit of a delay. At the time the serum lactate level was done, the VBG at that time showed a lactate of 8.1. So we can see there's a little bit of a difference in the lactate levels, and I'm going to go into that in a bit more detail later. The serum osmolality was elevated, calcium was a bit low, and the highest recorded ethanol level was 0.23, and that was a bit later during her inpatient stay. She went up to ICU. She eventually did start on an IV ethanol infusion as well as hemodialysis. She spent 6 days in ICU, sent home after a week. Came back the next day to ED with some delirium and was admitted under gen med for a further few days and went home after that. Any questions at that stage or this stage? Because now we are going to get our game face on. So I'm going to exit out of this. We are doing a Kahoot quiz. If I can get it to work. All right, give me a sec. Oh, just move that out of the way. Perfect. So I think, unfortunately, there's a limit as to the number of people who can actually join this Kahoot, but I would like for as many of you as possible to join. And if we don't get in, then still just try and get your answers. You can even pop them in the chat and someone can moderate. But we're going to have some fun because I think we've had enough sitting down and listening for now. We're going to get some action.
Yeah, and those who are unable to join, yeah, just pop the answer in the chat group. Obviously, you won't be able to calculate the points and stuff for you, but
Yeah.
there'll be some bragging rights if we get some correct.
Joining no longer available. All right. Thanks, guys. Let's start. Question 1, methanol toxicity. Primarily causes injury through the accumulation of what? Good. Most people got the right answer. Formic acid. Alrighty. Next question. The bud. I like it. You'll have to eventually reveal who you are. We'll get the podium winners to give us their real names. Next question. Still methanol poisoning? What are you going to use to try and enhance the metabolism of the formic acid that has been formed? All right. So folic acid is specifically used in methanol poisoning um, because it is related to the formic acid and you can increase the excretion of it. Oh, some new people on the board. Alrighty, next question. Now we're on to ethylene glycol, most commonly associated with what sort of organ damage? Yes. So the damage is actually caused by the calcium oxalate crystals, and we'll go into that in a bit more detail shortly. Alrighty, NV. Let's go. What pattern suggests early toxic alcohol ingestion in terms of blood blood analysis? Excellent. So very early on, sometimes the osmolar gap is the only abnormality you'll see. The anion gap might still be normal. The anion gap is often a delayed thing. NV's on a roll. Next question. Which one causes ketosis as pretty much the only abnormality? Yep, isopropanol. Excellent. Most people got that. It's one of the less common toxic alcohol presentations, but definitely important to know about. Alrighty, we have a toxicology expert on our hands. Next question. Blurred vision, headache, hagma. What's the most likely toxic alcohol in this setting? Methanol. Yeah, it's a pretty standard toxidrome. It's quite typical. Blurred vision. They usually get vision changes and it's often the methanol. Next question. Well, NV. Yep. Doing well. How does fomepizole work? Yeah. So it's not so much about the elimination, it's more about the process of metabolism. So it actually inhibits the alcohol dehydrogenase. And that's why it works for multiple toxic alcohols. NV is absolutely leading the way. Can't wait to find out who it is. Question 8. Why do you get hypocalcemia in an ethylene glycol poisoning? Yeah. So it's a toxic metabolite. It binds to the calcium by the oxalate binds to the calcium, and that's why you get hypocalcemia. Still there. Next question. Two more to go. This is a true or false. Does a normal osmolar gap exclude ethylene glycol poisoning? So we mentioned that an osmolar gap is raised, but does a normal one exclude it? Correct. Little tip, most exam questions are going to be slightly leading questions with this kind of theme. Good. So you can still have a normal osmolar gap and you can still be poisoned by ethylene glycol. Or 8,000 points. Last question. Anyone want to take over? Let's go. What do you normally see in a severe methanol poisoning for acid-base analysis? Well, that was quick. All right. Correct. Yeah. So you normally get the hagma. Fantastic. Let's see. LJ. James. Well done.
Do the
All right.
do the winners wanna come on and just say who they are? Who's LJ?
Don't be shy. Announce yourselves. We'd like to applaud you.
And who's NV more than anything else? Looks like they're a bit shy.
Aww.
Nobody wants to hog the glory. LJ is Liam Johnson down in Geelong.
Fantastic. Well done, Liam.
Well done.
Perfect.
Hi,
All right.
James. I work at St Vincent's.
Awesome. Thanks, James. Well done.
And no envy. You're allowed to
Liam
claim
apparently
glory.
is a TS1 trainee, so well done, Liam. You looks like a budding toxicologist there, but we don't
Yeah,
know who NV
absolutely.
is. NV
Fantastic.
might be someone with some experience, perhaps. Who knows?
Fantastic. Great. Thank you for joining me for that. I'm going to stop this share.
We
I'm
had
just going to
one
close it down to
question,
me.
Danielle, from Janice. I think she said she asked, "How do we know the metabolic acidosis is caused by the lactate plus ethylene glycol? Is there a way to calculate it?" I think you did cover it in your calculations. I guess it's a part of the clinical picture as well.
Correct.
It's not really a pure calculation because it's a combination of the clinical exam, the history, the sweet smell, the acidosis, the lactate rise, and of course, if you have the facility, the osmolar gap and things, and that clinical picture also presented a lady who presented with hypoglycemia as well. So combination of all of those things, not really just the acidosis itself, but yeah, I think the calculation of acidosis is just exactly how you present it, but it's just an aid to your diagnosis and treatment sort of targets and things.
Exactly right. Thanks, Abra. Okay. I'm going to
Um,
go. Sorry, carry on. All right. I'm going to. Oh,
Danielle,
no. Yep,
sorry
yep.
to interrupt. There's a comment from Nikki V. Hi, I'm NV. Microphone didn't seem to be working. Thanks for the great quiz. So we found out who NV is. It's Nikki V. Well
Fantastic.
done.
Well done. You don't need a microphone to win a quiz. Great job. Cool beans. All right. I'm going to go a little bit into detail about what ethylene glycol is, how it is toxic to you, and what we're going to do about it and why. So it is often it's a colorless, it's an odorless, it's a sweet tasting organic compound. But once it mixes with gastric juices, it often does form a pink or sometimes green, as in these pictures, liquid in the stomach, and that's why the notes once the patient had the nasogastric put in specifically mentioned pink liquid coming out. It's used mainly as antifreeze. It's actually also used in the production of clothing, polyester fibers. So, you need a somewhat decent amount to get to toxic levels. And that's why it's usually an intentional overdose. So less than a mouthful of an accidental overdose is actually benign and you don't need to do anything about it. Similarly, dermal and inhalational accidental exposures does not cause toxicity. The toxicity is actually from the toxic metabolites. It's not from the chemical itself. It's rapidly absorbed. You reach peak concentration within 1 to 2 hours post-ingestion usually. And the toxic effects are quite widespread. Symptoms can affect multiple body systems. And of note for CNS, you can get quite delayed neurotoxicity. So often up to 3 weeks post-ingestion, there's some reports of people still complaining of cranial neuropathies, particularly as a delayed form of neurotoxicity. So ethylene glycol levels themselves are usually not available. They need to get sent off to specialized laboratories, big delay, and sometimes just not even accessible. And so in order, similar to the question that was asked, in order to diagnose this, we have to rely on clinical features as well as surrogate markers in bloods. And those surrogate markers we've already started to talk about being the anion gap, the osmolar gap, the pH, and also a lactate gap, which we'll talk about in a minute. In the early stages of toxicity, the osmolar gap is the thing that changes first, and then the anion gap and the pH is often a delayed effect. Co-ingestion of ethanol sometimes happens, and we know ethanol is a treatment for it. So if you're drinking ethylene glycol as well as ethanol, you would still potentially get toxicity from the ethylene glycol, but the effects are delayed. So co-ingestion of ethanol actually delays the onset of toxicity from ethylene glycol, but you can still get toxicity from it, even though you're co-ingesting the antidote. The best predictor of severe toxicity is the high anion gap, even though that's not the first thing to change on the bloods. So how does it actually work? How do you get toxicity from it? So it's mainly a direct osmolar effect. The toxic alcohol itself causes the osmolar effect, and the metabolites cause the other anion gap and acidemic effects, and that's why those are often delayed. So the first thing you'd see is the osmolar gap because that's the actual effect of the toxic alcohol, and then the anion gap is delayed because you have to first have that metabolized into the toxic metabolites, and that's what the effect is on the anion gap. So an osmolar gap just means that the presence of, there's an abnormal solute that is present in significant amounts in the blood. So toxic alcohols is one of them, but mannitol is also another example. So you can get high osmolar gap from mannitol. The toxic metabolites for ethylene glycol are glycolic acid and the calcium oxalate, which we've already briefly spoken about. And those are the things that cause problems. So the glycolic acid in particular, that is what causes the severe anion gap metabolic acidosis, and that is nephrotoxic. And the calcium, the oxalate binds to the calcium, and that deposits into tissues, particularly the kidneys, and causes nephrotoxicity, acute renal failure, renal tubular acidosis, and can affect other organ systems like the myocardium as well. The lactate gap is interesting, and the lactate gap just means that there's a difference between the serum lactate level that's measured and the point of care lactate level that often comes on a VBG. The VBG will overestimate the lactate because it's falsely elevated in ethylene glycol. There's some measurement with chemicals and the reactions that a point of care lactate will incorporate the number that the ethylene glycol is metabolized to, and actually will falsely elevate the lactate. There's interference with the enzymatic assay. And therefore, the laboratory analysis of the lactate is more indicative of what the true body lactate response. But when there's a lactate gap, that's often diagnostic of an ethylene glycol exposure. I don't know if I explained that properly. If you want me to go through that again, please ask me. Or we can go through it again at the end. So Oxalic acid is the metabolite that binds to calcium. It forms the calcium oxalate crystals that you can see under the microscope in that picture, as well as dropping your serum calcium level. So it causes hypocalcemia. Another, I don't know what the availability of a Woods lamp is in every ED. I believe for this patient it was attempted and it was documented that there was an equivocal result. But you can use a Woods lamp to try under fluorescence, see if there is sodium fluorescein, which is present in antifreeze. So whether you actually have a bottle of what the patient was drinking, or potentially you could use nasogastric fluid output to actually test whether there is immunofluorescence of that liquid, and that would indicate ethylene glycol because of the sodium fluorescein that is found in it in antifreeze. For this particular patient, we're going to go back to working out our numbers. So we worked out they had a Hagmar. We saw that there was an osmolar gap because the osmolarity was higher than normal, and there was a lactate gap, given that it was delayed, as I said, because the first serum lactate wasn't measured until after they got to Frankston. So it would be really interesting to have seen what the initial lactate gap would have been, because I suspect it would have been higher than 5. How is it treated? So any delay in treatment results in worse outcomes, and I suspect that's why this patient received nasogastric ethanol prior to being intubated, even though it was like a 5 or 10-minute difference between starting the antidote versus patient being intubated. Activated charcoal doesn't work, so it's completely useless in this situation, does not bind alcohol, so you have to move straight on to the antidotes. Fomepizole and ethanol, how do they work? They are competitive inhibitors of the alcohol dehydrogenase enzyme, and so it actually blocks the conversion of the toxic alcohol to its toxic metabolites. Fomepizole is actually preferred. It's definitely preferred in situations such as a pregnant patient, a pediatric patient, and patients with known liver cirrhosis, because those are the situations you don't really want to be giving patients ethanol. So fomepizole is definitely safer, particularly in those situations. It also has a longer half-life, but it is more difficult to access, and it is much more expensive than going down to the bottle shop and getting ethanol. They both need special access schemes through the hospital pharmacists, so it's not something you usually just have on standby in your ED fridge. So it can be a little bit tricky to get hold of after hours, particularly if you need to go through the on-call pharmacist. Enhanced elimination. So it has ethylene glycol's got a low volume of distribution. That's why hemodialysis can be quite helpful. What others can be used? So we can use pyridoxine. It also helps to convert the ethylene glycol to non-toxic metabolites. So something extra to bear in mind when we are starting the ethanol treatment, to give them some pyridoxine as well. Of note, so this patient didn't really, but sometimes with more significant toxicity, patients will compensate their metabolic acidosis with a high respiratory rate. And therefore intubating them can be quite tricky. So the book suggests actually giving them some bicarb before intubation, and keeping up with their pre-intubation respiratory rate. So actually hyperventilating them and potentially giving further doses of bicarb after intubation, just so they don't crash and burn on induction. So coming to the end of a toxic alcohol talk with a little bit of a slant on ethylene glycol because of this particular patient. So methanol specifically causes vision changes and a Hagmar, and that's through formation of the formic acid toxic metabolite. Ethylene glycol causes more oxalate crystals, affects the kidneys, so you often get a kidney injury with the Hagmar. The Hagmar can be delayed. You usually get osmolar gap before the anion gap. That's from the toxic metabolites being glycolic and oxalic acid. And isopropanol, slightly less known or less common, but that causes often ketosis without any other metabolic abnormalities, and that's from the toxic metabolite acetone. Early on, you usually get the osmoligap. Later on, you get the Hagmar. Fomepizole is preferred, but is often much more difficult to access, and therefore we usually go straight for IV ethanol if you've got it, or bottle shop ethanol if you don't. And dialysis can be very helpful for these patients because it helps to excrete and protect the kidneys, particularly from those toxic metabolites that we've spoken about. So that comes to the end of my talk. Happy to take questions. As I said, I'm not a toxicologist, so I'm happy to try. Anyone else can jump in with better answers if I don't have them. Thank you very much.
Thank you, Danielle. I'll just wait a few seconds to see if there's anybody who wants to have a question or anything. I think it's important to think about what you would do in regional rural hospitals. A lot of the trainees now, given the new training program starting next year in terms of the regional rural requirement, will need to work in places away from tertiary centers. So thinking outside the box, dealing with complex cases when they first present, and actually putting your clinical acumen to the test is very important. So, it was quite a good case, and thanks for the quiz. There's no questions in the chat at the moment. If there are any later, I'll just bring them up later.
Perfect.
I just now we have a talk by our network DMT, Mohan Kavalanathan. It's a case-based presentation of a complex resuscitation that Mohan was involved in. So I will welcome Mohan. Let me just give him a couple of minutes to set up and to start sharing, and we'll take it from there. Welcome, Mohan. Thanks so much. Is your microphone working, Mohan? Can you just check? I can't hear you.
What?
Yeah, I can hear you now. Yeah.
Ah, apparently when you turn 50, an angel visits you in the middle of the night and makes you unable to use anything computer related. Um, so we had a guy who had come in with a run of toxic alcohol ingestion for like a three week period, to the point where every time we called the Austin, they went, "Is it this guy?" And they just said, "Yeah, just we'll just send you the fomepizole."
That's correct.
These things happen. Okay. So we're going to talk about some complex resuscitation stuff in the third trimester. Uh, Abraham, probably going to need your help on sharing. I'm assuming.
You are able to share. I made you co-host. Should be able to share. Yep, I can see
There we go.
the screen. Yep.
Nice. It works. Yay. But this means I can't see the screen. So if there are any questions, Abra, can you just send me a
Yep.
WhatsApp or just interrupt me?
No worries, will do.
All right.
Thank you.
So I'm gonna start with hi, my name is Mohan. I'm one of the DMTs at Bayside Health Peninsula Care Group. Still getting used to the name. Going to run through a case that I saw and my reflections on it. It is one of those rare things that happens. A word of warning, there is unsurvivability in some of these in this case. Um, but on the plus side, there are no cahoots. So you won't be asked any questions. So I'm going to run through complex resus in the third trimester. So like most good cases, it starts on a Friday night. and you have left the department. And as you are leaving the department, your senior registrar goes, by the way, before you go, we've got this. So a 28-year-old lady who's coming in about 30 minutes, who's third trimester pregnant, has had abdominal pain and syncope, with an unrecordable blood pressure. Um, they called us as they were resuscitating and gave us adequate notification. They'd given us some fentanyl, some metaraminol, started a NORAD infusion by the time they got to us, and given her 2 liters of saline. Those were her current ops, so tachycardic, hypotensive, not terribly tachypnic, but a bit, and oxygenating well. Um, so I would prepare for this by doing a couple of things. Abra, any words on any thoughts on suggestions from the chat?
Um, Nothing at the moment, Mohan.
Okay.
We've got someone actually commented just now saying Janice said call ONG.
Yes, that is a good start. Call ONG, very good.
Lucy says call Pete's.
Well, Lucy would. Oh wait, no, she's done her Pete's job. Yep. So very, very good suggestions.
Got
This is
Anthony Coco saying call blood bank.
Floral Blood Bank. There we are. So those are the people we called. Uh, so we had us, anesthesia, ICU, obstetrics, pediatrics, hematology, and radiology. For a couple of reasons. Because any suggestions on a differential diagnosis for maternal shock in the third trimester?
We got Janice saying placental abruption. James
Excellent.
Hedge saying abruption.
Yep.
So 2 abruption suggestions.
Yep. Good. Aortic
Abigail
dissection.
Popiel says aortic dissection. Srigala says PE.
More PE.
James also says PE.
Yeah. Is there a unique embolus that you see in third trimester pregnancy out there? Absolutely right. AFE.
Amniotic fluid embolus. Yep.
Yeah. AFE. Okay. So this is my hastily put together document on what I think causes maternal shock in the third trimester. So abruption, clearly, previa, rupture, or uterine atony, aortic claval compression, which is expected, and cardiogenic, which is really interesting because some, particularly in undiagnosed patients, it is the leading cause of death in women without prior cardiac history. Never forget sepsis, decompensated eclampsia, as the IC kicks in and they start leaking everywhere. Interestingly, the literature puts amniotic fluid embolism as in its unique category, in its own category, because it's cardiogenic plus distributive, plus to some degree hypovolemic. So it's a combination of things. Spinal toxicity stuff, I think we probably don't see as much of that, but it's something to include in your differential. So if there is a question in the exams, this might be a good one to remember as a list. Nice to see everyone still being splenic artery aneurysm rupture. Impressive. All right.
Room 7 in an undisclosed location.
I know.
Area 51.
This looks like Orson Welles, man. Okay, so we needed to make some decisions, and so I probably had about 15 people in the room. So like you, Abra, it's 0 point survey. So there was myself, my senior registrar, and my junior registrar. We had anesthetic consultant, anesthetic registrar, ICU consultant, ICU registrar, ICU resident. Um, we had obstetrician, obstetric registrar, obstetric HMO, and ANUM from birthing suite. And then we had pediatrician, pediatric reg, pediatric HMO, and ANUM from peds. And then we called the lab to say that we'll probably need an MTP ready to go. And we just let radiology know that we might need a quick um, turnaround for imaging and stuff. So there were a lot of people, and we set up two rooms, one for mom, one for pop. Um, I did have three critical care nurses extra. I don't know where they turned out of, but I just love that people went, oh crap, there's someone sick coming in. We're going to all turn up and help out. I think they were from ICU, and so I assigned two of them to massive transfusion, and one of them I said to be the communication liaison between family, patient, and ourselves. Uh, I mean, we were slightly oversubscribed, but I think it was necessary at that point. Um, so we ran off some bloods. Um, I think we'll go through some basic things. Markedly acidemic. Oh, that was an arterial, by the way, because we had ICU. They just dropped an outline in. Anemic, lactates phenomenal. Glucose was 24, stress response. Um, and then we had hematology stuff come through, still anemic. She was on 20 in NORAD and had a blood pressure of about 85 still. I think the other interesting ones are troponin of 5,754 and a Kleihauer that was really, really low. So my only words to our obstetric consultant and the team were, you guys do your work, but all I want to do is a bedside ultrasound. And if there's a fetal heartbeat, we go straight up to theater. Unfortunately, there was no fetal heartbeat and there was no blood flow on Doppler. And so I stood back and let the obstetric consultant have a conversation with everybody in the room. And we then had to decide at what point we needed to go up to theater. Um, it was really interesting because there was a discussion about whether we image first or not, because the presumption was that this was a concealed abruption. So not one that's overt with bleeding, but she was pretty hemodynamically unstable. Somebody did an ECG, which shows a right axis deviation. We checked the leads and a sinus tachycardia, but not much else. So, can I get some suggestions from the void on what do we do next? She's bleeding. She's shocked. There's no fetal heartbeat. She's in a left lateral tilt position. And we need to look at controlling the presumed site of hemorrhage.
Would you move along the lines of, I know it's not postpartum, but would you sort of go along the lines of a PPH type picture and then look to control the uterine atony and massive transfusion protocol?
Yep. Certainly fill the tank. Uterotonic is a bit tricky if there's still stuff within the uterus. Resuscitative hysterostomy is a good suggestion. rescue resus and a laparotomy. Yep. Hey, I can bring up the chat. This is pretty cool. Um, so we had a 2-minute discussion on what we needed to do next, and there was a discussion whether we go imaging to identify a source or do we go straight up. Anesthetics elected to intubate, so we intubated her in the department, and that was really interesting. Because we then gave a, I mean, that was the fastest I've seen 4 units given. We gave her 4 units in like 45 minutes. It's crazy fast. Um, Amoxicillin for chorioamnionitis, some analgesia, and then anesthetics took over the intubation. And our NORAD jumped up. So everybody was a little bit nervous about the induction, but rightly so. It's a reasonably underfilled pregnant woman who's going to desaturate really, really, really quickly. Blood given through a RIC line? No, she was a little bit too shut down for a RIC. We attempted a RIC, but it didn't go in particularly well, and later on caused some complications. So we had two 18s and a 20. So we used what we could. I think our most secure resuscitation line was a blue, a 22 gauge, but we got two 18s and a 20 in, and we gave her blood through the 18s. Um, so tiny, tiny doses of induction. We removed the left lateral tilt, which tanked her blood pressure within a minute. Really quick induction, really quick tube, and then restored her to the left lateral position again. And then, following a robust discussion, went straight up to theatre. NORAD went down to 8 once we gave her some blood, and post-induction went as high as 40 and then tapered down. But that's just the vasoplasia and the under-resuscitation that does that. Her HB prior to going to theatre was 113, which was reasonable, but she was still pretty shocked. So went up to theatre, and as sometimes happens, she arrested in OT while they were prepping the abdomen, so they did a resuscitative hysterostomy. When they opened the abdomen, obstetrician took the general surgeon up with him, and they found a hemiperitoneum. They did a resuscitative hysterostomy, stillborn male. It was clear liquor, so it didn't look like a abruption. And then the obstetrician extended the incision after closing the uterus, and packing the lower abdomen, and then identified blood in the left upper quadrant. So identified a splenic artery aneurysm. So whoever said splenic artery aneurysm in room 7.
Room 7 in Area 51.
I know, room 7 in Area 51. It's pretty spot on. So at that point, because she had arrested on the table, we had anesthetics, ICU, myself, vascular obstetrics, and general surgery in the room. There were a lot of people. Surgery. So the vascular surgeons then took over. They did a splenectomy. Sorry, general surgeon did a splenectomy and a splenic artery ligation. We're in the ED for the win. Nice. Room 7 is Maroondah.
They're
Nicely done.
actually, I think, isn't Frankston the ONG and pediatric hub for Maroondah now? No, actually for Alfred.
Well,
Maroondah is a different center. Yeah.
yeah.
Well done, Maroondah. Good job.
Yeah. So general surgery took out the spleen and then ligated the splenic artery and vein, and then vascular went in and coiled the stump of the splenic artery. really interesting. Surgery was about 4.5 hours. So this went on from 2:30 to about 7 a.m. And she recovered. Um, but there were a couple of things that I guess this case brought to mind. So, yeah, we have another 30 minutes. Let me pause for a second. Right. Does anyone have any questions about the case at this point? If
There
imaging was
was a question about IR coiling. I don't know if you addressed it.
so vascular did IR coiling in theater. So you know how we have the hybrid vascular theater that we could do IR in, like down in theater 10.
Yeah.
That's where. Good question, Anthony. Did bedside ultrasound show abruption or intra-abdominal free fluid? So obstetrician was handling the ultrasound. Um, it's one of the questions I kept asking myself, could this have been prevented? Could we have gone to theater with a clear diagnosis? And I think there's no right answer, and it really depends on your gut feeling. Um, Having the expertise on site at the time was useful because one of the learning points is even in this day and age, a laparotomy is still an investigation in expert hands. It's not a treatment. And so I think the fact that when the obstetrician opened the abdomen and saw hemoperineum, it was fairly straightforward. It was not coming from the uterus, it was coming from somewhere else.
Just the question I had, Mohan, was the ultrasound that they performed, was it did they just look at the uterus or did they
Yes.
do a fast?
So the obstetrician looked at the abdomen and the uterus, but didn't comment on findings in the uterus. Sorry, didn't comment on the findings in the abdomen as opposed to commented on what was in the uterus.
Okay.
And that's why there was the discussion of do we go to CT first before we go upstairs?
And the reason I was asking that, Mohan, was because I think a lot of the trainees might not be aware of this, but when you do a fast examination for intra-abdominal bleeding, and let's say you have a splenic artery rupture or splenic rupture, even if the blood, if you actually are assessing the patient, let's say an hour or 2 hours later, the hemorrhage from the spleen or the splenic artery can appear almost isodense and can actually look the same as the
Oh,
splenic structure. So when you look at the spleen and the surrounding structures, you may not be able to appreciate that there's actually bleeding there because the blood that's clotted looks almost the same sort of homogeneous sort of appearance. So you can't actually tell whether there's a laceration or not or a collection of blood.
so it
That's quite a common thing.
gives you the same echo texture.
It gives you the same echo texture, and so it's very hard to actually pick it up unless you have done a lot of ultrasounds and are used to seeing it in trauma all the time. And also to note that, as with any ultrasound sort of issues, that ultrasound is very specific, but it's not a sensitive examination. So if you don't see something on it, it doesn't mean that it's not there. But then, yeah, definitely the splenic hemorrhage is a known issue with fast examination that when you look at it to the untrained eye, it might look normal, but it actually isn't. So that's why I was asking, because I think if you think about ONG expertise, they're quite used to doing obstetric ultrasounds and gynecological ultrasounds, but not used to looking at other structures in the abdomen unless they're specifically trained in that.
Okay, cool. Thanks, man. So next step was to continue on with a resuscitative hysterostomy. So let me bring up those slides. Okay, I just need to reset my screen a little bit. And We'll do the share thing. Where's the share thing? Here we are. Ta-da! Okay, so uh, resuscitative hysterostomy, one of those rare conditions where we get to do, well, preferably not us, preferably the obstetrician, but one of those situations where it helps both the baby and the mother. I'm assuming everybody knows that it needs to be done within the first 4 minutes of maternal arrest, but the data has changed. So I'm sorry if this is a reasonably busy slide. Um, so the whole concept of resuscitative hysterostomy is what was previously known as a perimortem C-section. Is that you take the fetus out of the uterus, you essentially pull back about a liter of blood from a high volume, low resistance circuit in the uterus back into the central circulation. And the old data based on anecdotal evidence was you want to do it within at the fifth minute of CPR. However, there have been quite a number of case series and case studies that show as soon as practicable, regardless of viability or elapsed time. So when you decide, yep, that needs to happen, you make it happen ASAP. And so the current ILCO guidelines recommend that preparation for delivery should begin simultaneously with resuscitation if the maternal condition is not rapidly reversible, regardless of fetal viability or elapsed time. I've got a PDF of the information that I can share with the group. And so there are meaningful survival outcomes beyond the 5 minute window when we do high quality resus. Now, granted, this lady was peri-arrest and shocked, but I think once they started prepping the abdomen in theater, it was clear that she was in the right place at the right time. Longest maternal survival with normal neurological function is 29 minutes, and longest neonatal survival was 47 minutes, but there have been good outcomes as early as 26 weeks gestation. Right. Does anybody know what the abdominal findings should be to decide whether it's viable or not? So they say viability after 24 weeks, right? Yeah, absolutely right, Emily. Above the umbilicus, which is good, but not. That's what we are always taught. If the uterus is above the umbilicus, there is a possibility. Um, so if I'm going to change your mind about resuscitative hysterostomies, what I would say is consider it if the maternal condition is not rapidly reversible, and then make it happen. Any questions about resuscitative hysterostomies? Well, one of the questions I was thinking about was, do you do a traditional fan and steel incision? Do you do a vertical incision? Uh, I think I would leave that up to the obstetrician. Um, I think like us, do what you are most comfortable doing, particularly in a situation like that where speed is critical. That is not the time to learn a new technique or try something new. So, absolutely I think when we are taught to do resuscitative hysterostomies, it's a vertical incision down the midline from the umbilicus, which is what the obstetrician did. Uh, and some of them prefer to do fan and steel incisions and get the baby out. Um, Part of that reason is for further viability, you don't want to scar the uterus or create complications for further pregnancies if um, they decide to go ahead and have another one. Um, so, going to talk a bit about splenic artery aneurysms and why they happen in young women. So, another little bit of a literature review. Um, so, classically in pregnancy, it tends to be a couple of things that happen. Usually, the first two. So, estrogen and progesterone with relaxin uh, will relax the splenic artery, and then as the uterus occupies most space in the abdomen, there's increased splanchnic blood flow, bit of aortic compression, certainly a bit of portal congestion, and that causes a splenic artery aneurysm to occur. And then it ruptures. In non-pregnant women, fibromuscular dysplasia. And then, of course, Marfan's and alpha-1 antitrypsin deficiency, or hereditary hemorrhagic telangiectasia, Osler-Grendy-Weber syndrome. But I think there is more information coming out, at least to us, about the whole estrogen relaxin thing. Um, in terms of progress, so once she got out of theater, there was an EBL of about 7 liters. We used a fair amount of blood in her. Um, I'm glad to say that she went home yesterday after an 8-week stay in hospital, uh, with a lot of follow-up. But her stay was complicated with a PE, a stroke, and some wound infections, which are not unexpected considering the severity of illness that she came in. Um, Now, I have a video, and I'm not sure if it's going to play or not. Of course, there's always a damn ad, but it's good that it's Flora. So, light bulb moments. If you are going to take anything from this, there has been a change in the indications for resuscitative hysterostomy. Um, Laparotomy is still sometimes an investigation and not necessarily a treatment. Uh, Causes of maternal shock are sometimes tricky and outside the uterus. But more importantly, I think there were more than 2 patients in this scenario. Um, and so one of the things I haven't touched on is how we dealt with family and the stillbirth. Um, ooh, thank you very much. Do you guys have any questions you want to ask?
I just had one, Mohan, about you mentioned about dealing with the family, and obviously you did allocate some staff members to have those sort of discussions and things. And
Yep.
is there anything you can enlighten us about how the staff members were feeling in the room, and the impact on the people doing the resuscitation themselves, because they would have found out obviously at the same time as everybody else.
Yeah. So, good question. Certainly at the moment of the ultrasound, There were some very quiet tones about communicating that ultrasound finding. Um, Reassuringly, the team, as we are trained today, family stays in the room, right? Um, and so we communicated that quietly amongst the group. We had a moment of sadness, and then we got on with our job. The aim was to, get mom up and essentially stop the bleeding. Um, there's a question from Janice about multidisciplinary debrief. So yes, we did. Certainly from a medical and nursing perspective, I think for the guys who are sitting their exams, one of the things I would recommend is notifying your head of unit before you go home, either via email or a phone call. Um, Simply because your director needs to know the tone of the department at change of shift. Um, I think we had so everybody debriefs differently, right? There are some people who need time to process the emotions, and there are some people who, if they process the emotions over time, tend to spiral. So it's tricky. Um, my approaches tend to have more than one debrief session, so not just a hot debrief or a cold debrief, but actually have a debrief where you give people your phone number, give me a call. Or, this is nursing leadership or medical leadership, give us a call when you're ready to talk. Um, I think the data is a little bit heterogeneous because it depends on feelings, but I think everybody should be given an opportunity to express their thoughts. Uh, I think we were reassured by the fact that survivability was good, but I think we struggled with the fact that it was a stillborn. Uh, One of the things that we uh, talked about prior to going up to theatre was the preparation for a stillbirth. And I think if you work in a hospital with an obstetric service, it is a good thing to talk to your obstetric team about what your specific plan of action is for a stillbirth in the department. Because everybody does it slightly differently, and it's nice to know what your local practice is. Uh, any other questions? I think I've got 14. I've got another 10 minutes. Huh. I must speak faster.
If there's no other questions, I'm happy to sort of start a bit early as well and spend a bit more time. That's not a problem at all. But
Awesome.
if
Thanks,
anybody has
Abra.
any questions, please let us know and I can forward them to Mohan. I'll put my email in the chat as well. And things. Thank you.
Abra, do you want me to share the literature review stuff on the chat, or do you want me to
Yeah,
just
please.
send
Yeah.
it to you?
I think if you can like share in the chat for now, the people who want to click and save and things, that'll be fine. I
Okay.
can get off you later. That's fine.
All right. Cool. Thanks, man.
All right. Just gonna share my talk. Okay. So I thought as a fifth and final talk of the day that we spend a bit of time on something that's useful to the registrars. And I wanted to focus on an area that's developing every year with the fellowship exam. And obviously, like I hear from trainees about the questions that were asked in the exam, the SAQs and the MCQs. and there's more and more ultrasound in the fellowship exams. And I think this trend will continue. I don't think this will stop. And ultrasound in the exams is a weird sort of beast. I think there's when you look at the ultrasound curriculum, it's actually in three different places. There's obviously your general curriculum with medical expertise, but then there's also in it ultrasound in the investigations section of the curriculum document. And in terms of the actual criteria as to what and how it's assessed in all sorts of different formats. So the fellowship exam, even though in the investigations will say that AAA and FELS and EFAST are sort of assessed in your fellowship exam, they can actually ask you a lot more than just that. Because in terms of if you look at the actual content, the content also involves in medical expertise all the other conditions like dissection, PEs, cholecystitis, appendicitis, tamponade, and it doesn't really clarify the extent of the assessment that will take place for those because all of them are game. So if you think about if you're going to assess someone for investigations and modalities, well, you can pretty much ask any questions because a lot of them are clinical. So, and that's evidence in the exam as well. And the content will also come from the ultrasound modules. So it's very important to actually go through the ultrasound ASIM modules to actually make that part of your fellowship training. And I would encourage you to do that earlier on in your training. If you have done the modules earlier on, then when you're actually preparing for your fellowship exam, you'll actually be able to repeat them again when you're actually preparing, make notes, and sort of revisit that because every time you revisit it, you'll see something different. Today's session, I'll focus on what I think is high yield in the sense that these are areas that are important to know and important to be able to answer, but not your traditional questions. We don't want to, ask the same pneumothorax. What's it's a classical MCQ questions that's been there since 2013 about showing a barcode sign and asking the question as to what that is. I think there's a lot more to it than that. So we'll cover some lung ultrasound. We'll cover some AAA questions. We'll do a rush protocol question, as well as cardiac tamponade, massive PE, and a bit of cholecystitis and appendicitis. These are all things that will be useful to you in your clinical work, but also for exam purposes. At the end of the talk, I will put up a link for the SAQ questions that are the basis of these slides with the answers. So you guys can just print that off and use them for your fellowship training. And also I've created 20 MCQ questions on ultrasound as well, which you can actually use. So you can print that off as well at the end of it. So don't bother taking any notes or anything. You'll be able to get all of this later. So we'll start off with lung ultrasound. And we focus on B lines and pneumonia in this one. And I'm using static images, not actual videos, because your SAQs are not going to have videos in them, at least not at this time. So in terms of like B lines, really we're talking about the artifacts that you see when you actually do a lung ultrasound, looking at the pleural space. So in this image here, we have the rib shadows, one on either side, the black sort of shadows going downwards. And then you have these like a torchlight artifact coming from the pleural line up here, which is a bright hyperechoic feature. These pleural lines, these sort of like torch-like artifacts should actually project more than 15 centimeters, which to be actually truly classified as a proper B-line pattern. So there's a few criteria for those, but my question really is something a bit out of the ordinary. The question is, like, for example, in the fellowship exam, you might be like given a case to say, 85-year-old person, like male comes in with shortness of breath on BiPAP and is now in resus. The patient's hypertensive, hypoxic, has a history of congestive heart failure. List 7 features of B lines or lung ultrasound that you've performed to this patient. So you'd be hard pressed to be able to write all 7 if you actually haven't studied this before. And the exam is always asking you something that's beyond what you normally would project. So majority of people doing the exams will be able to write that it's a comet tail appearance. There'll be people who are clever enough will write that it's a hyperechoic bright line and it's well-defined margins. The other feature, like I mentioned, extending beyond 15 centimeters from the pleural surface. So that's kind of one of the sort of main things. And most people will write those four. But then there are other features that you'll also need to remember is that the B lines will erase your A lines, which are your horizontal repetitive lines, which are another feature of artifact in a normal lung. And your B lines should also move in concert with lung sliding when the sliding is present. That's another feature of B lines as well. And of course, the main one is the B lines arise from the pleural line, not from the subcutaneous tissue. That could be one potential SAQ exam question. And obviously, that if you are asked several features on one subsection, you may not get full marks if you don't put all of them down. So that's a possible sort of thing to know. The other thing, a potential question, obviously, it's a very popular one, but I'll put it in there anyway. I think it's still high yield, is other causes of B lines. So not just the advanced practitioners will know that B lines don't just mean cardiogenic pulmonary edema, but can also stand for an ARDS pattern. You can also see B lines in pulmonary contusions. And a viral or bacterial pneumonitis can show them as well, and pulmonary fibrosis as well. Of course, in cardiogenic pulmonary edema, the B lines and the B pattern, which is more than three of them in one pleural space and multiple pleural spaces, is actually found more widespread than just one isolated section of the lung. So that's important to realize. But then B lines per se, you can see them in those features as well. So that's very important to remember, and a potential exam question there. Let's look at ultrasound features of another common condition that we treat in the ED is pneumonia. So a potential SAQ question could be a 45-year-old male presents with shortness of breath, fever, and productive cough for several days. And essentially, you suspect it's a pneumonia. You've performed while waiting for an X-ray. You performed the localized ultrasound. And can you list 5 ultrasound features of pneumonia? So some of the features to know of, and I'll cover these with some photos because it's important to know. The common sort of things you're looking for is obviously looking for consolidation, but what type of consolidation are you looking at? The consolidated lung and a purely beautiful consolidated lung will look essentially like the liver. So imagine looking at something that looks like the liver, but it's above the diaphragm, not below the diaphragm. So essentially that's your normal, like a normal loss of echogenicity. So it looks like that. There's some specific signs like spine sign, for example, shred sign, and then sonographic air bronchograms, which can be static or dynamic. And of course, a paraneumonic effusion, which is a collection that's also a feature of an advanced pneumonia as well. So those are 5 features that you look for. Now, you could potentially be asked to explain what those features are in a segment where you might have a column for each sign, or like a little row adjacent to it, asking you what the features actually mean. That's a potential there. Let's go through the actual signs themselves, what they look like, just so to refresh your memory. So just with normal lung, that we just looking on the left-hand side of your screen, you're seeing obviously your rib shadows, which are identified on the screen there. And I talked about the A lines that you can see in between the two in the actual pleural space, which are the horizontal lines that you see there. And of course, the arrow pointing to the pleural line, which is a bright echogenic line right at the top. That's your normal lung appearance that you want to see in someone. Now, if you, at this particular depth, looked at a pneumonia, you can see something that is termed as a shred sign. This is one picture of it. A shred sign essentially means there is a bit of consolidation, and that consolidation gives you an appearance from the pleural surface of your classical shredded paper. So when you have like a paper that's like you're like fully wet and you pick it up and often it tears and fragments at the corners, and they'll actually show you all the little features of it. That's really what it appears to be, a shred sign. And that's one of the main features of that to be able to see. Now, I've got a little video here. You won't be able to see it on a video, but I thought this is, in addition to your picture, will be a nice one to see. This is what it looks like on a video, the shred sign itself. So again, the shredded paper appearance from the pleural surface, the bright echogenic little blotches that you can see on top, that's your shred sign. This is a feature that you might see in a pneumonia. Another little video of a shred sign. This is moving from normal lung down to the actual right upper quadrant, where you can actually see a combination of 2 things, actually. So you see a little bit of hepatization. So I talked about how the consolidated lung looks like the liver. So you can see on the right-hand side of the screen, the diaphragm comes in. And below the diaphragm, there's a bit of liver showing as well. And then when you actually look above it, you can actually see the consolidated lung. But then look closely at this red sign that's adjacent to that. That's again that feature of consolidation. So you can actually see that very clearly. It's a beautiful, beautiful ultrasound video. And that's like with red sign. So that it can be presented to you in the form of a picture as well. So that's one of the actual features. Now we talked about bronchograms. You can have air bronchograms that you can actually visualize. The one important thing to think about is in on ultrasound, air looks air like it doesn't look like dark well it like when air is moving surrounded by consolidated lung, it actually looks bright. So these little bright white dots that you can see poking out through holes and little lines are coming through as a patient breathes in and out are dynamic air bronchograms. So your ultrasound equivalent of your chest X-ray finding of air bronchograms. So that's really what you're seeing. Now you can have them static as well, where these little bright white dots in consolidated lung will just look to you as a static one. They don't move at all. That's entrapment of air. But when you actually have air that's able to move a little bit, that's what you actually see on a consolidated lung. So that's one of the other features. I thought I'd show a video of that so people who haven't done these often enough are able to actually understand what the actual question's asking and what to actually put down. So it's important to obviously not just rote learn and put down signs that you like remember, but know exactly what they actually look like as well. And of course, we talked about a paramnemonic effusion. This is a very vague example of a paramnemonic effusion, and I've sort of annotated it just to show you a feature that's relevant, and that feature is a spine sign. So essentially, your spine sign is, like in simple terms, your visibility of your spine, like your actual spine and vertebral bodies on the ultrasound, which you can see at the bottom of the screen here. This bright white echogenic line is the outline of your vertebrae that you can see on the lung ultrasound, with the diaphragm on the right, the liver, and there's an effusion there as well. And you can actually see the actual spine. So if you can see spine beyond the diaphragm, and that needs to be really well elucidated as well. That's obviously an abnormal finding. You can see the spine sign in both mnemonic consolidation as well as an effusion as well. Mohan seems to have his hand up. I can take his question.
There we go. All right. So, is the reason why you get to see the spine more clearly and the diaphragm more clearly because there's fluid there and fluid transmits ultrasound better than air?
Absolutely. So thanks for bringing that up. And that's kind of the main sort of reason why this happens, because, yeah, you're right. Anyone who's done ultrasound for a while knows that like you need to have a transmission of ultrasound waves through a solid object or fluid. And that's what really outlines everything. The sound waves don't travel very well through air, which is another reason why sometimes, for example, if your patient comes in with a pneumomediastinum, for example, and if you actually look at their lungs with ultrasound or their heart with ultrasound, you can often barely not make anything out at all because it's covered with air. And air is a poor transference structure for ultrasound. So you actually don't see any structures at all. So yeah, the presence of fluid and consolidated lung transmits the waves much better. So when you actually go beyond it, you can use the structures as a window to look beyond that. It's a good point. Thanks, Mohan. So moving on, that's covering lung. And I think those are good high yields or points to think about. And you can look at the SAQ questions the way I've worded them. I think that's pretty good revision as well. Let's look at aorta and what potential questions can come in the exam from an aortic like sort of image that might be presented to you. So in my experience, and also talking to previous trainees over the last few years about exam questions and what kind of things that have been asked and what can be asked in the exam question in the past, you could potentially be asked about, for example, identifying structures. So if you do get a picture on the exam, you might be asked about a structure, and AAA scan is a good one for that, because there are some particular things that you can actually identify on a AAA that are just that little bit beyond just saying, oh, this is liver, this is diaphragm, this is kidney, like you would, for example, in a fast scan. That would be too easy. You wouldn't ask that in a fellowship exam. But on a AAA scan, there are some critical views, and I find the longitudinal view of the aorta, as well as a transverse view of the proximal aorta, the really good money images for me. And the main reason being that if you can identify label structures on there, there's some key things to identify. So there are two main sort of key features, actually three, but in a longitudinal aortic anatomy, especially, you can obviously identify this in aorta. There'll be also, there might be a label for the spine as well there, but then you can actually see the celiac trunk. And if you can actually see something like this with two vascular structures close together, the top one is always going to be celiac trunk. And the one immediately below it, if you remember your basic anatomy, is going to be your superior mesenteric artery. So those are the key structures. And of course, if there'll be other labels there for the liver as well, because that's what you're using as a window as well. So you might potentially have 4 or 5 boxes there to identify, or labels there to identify. In a proximal aorta transverse view, you will obviously get the view of the vertebral body. You will see the aorta, which will lie to the right-hand side of the image, and you may see a branch of the aorta coming off it. If you do see a branch of the aorta coming off it, and then you see other vascular structures superior to it, that's almost certainly going to be the SMA that's coming off. And then the SMA will be closely related to your portal vein and your splenic vein. And of course, the pancreas on top of that. The large vascular structure that's immediately to the left of the image in this type of a annotation next to the aorta is always going to be your inferior vena cava. So I think these are the two main money ones that I think are present. There's a third one as well, which we'll cover later. With the potential of a abnormal image, I find one with the most amount of abnormalities would be a key one. I don't think you'll get one with just a dilated aorta. That'll just be too easy and not enough information there to be able to actually justify a mark. But for example, in this view here, you have a AAA with a mural thrombus. That's and a rupture as well. And that's kind of a really drastic image you might see, and a measurement with a scale that could be potentially an exam the question. Now, just to revise, a normal aortic diameter would be less than 3 centimeters. And the definition is obviously greater than 3 centimeters maximal diameter. You need to measure on ultrasound the aortic diameter from outer wall to outer wall. So if you have a measurement that's inner wall to inner wall, that's inaccurate. You need to have the cursor placed on the outer edge of the wall and on one side, and then the same on the other side. In terms of the rapid expansion, the literature says greater than half a centimeter every 6 months is too quick. That's rapid expansion. That's one of the surgical criterias. And another surgical threshold is greater than 5.5 centimeters in a male and greater than 5 centimeters in a female. These are obviously academic thresholds, and the decision making goes well beyond that. So you'll often find people with much larger aortas that are being like surveillance candidates rather than actually getting surgery. So this is again another larger and enhanced view of that proximal longitudinal view that I was talking about with the celiac trunk and the SMA. And the same token, again, the transverse proximal aorta view as well. So I would encourage you guys to do the AAA module on the ASM ultrasound modules page, because that does cover a lot of these images, and also the whole protocol of performing a AAA scan as well. And knowing what your credentialing criteria are important as well. A third view that I want to bring up is a classical view that, being a sonographer, clinician sonologist, we often love our signs, and we like to name our signs. I know some of you guys might have heard about the Mickey Mouse sign. Well, for an aorta, one of the classical sign is a seagull sign. So I guess this little structure here on the right-hand side of the screen looks like a seagull flying. So with the two wings, so that's kind of like what they're really sort of like saying with the sign. And what it really means is you're looking at the abdominal aorta at the celiac axis. And the split that you're really looking at is where the splenic artery with the celiac axis, the splenic artery comes off, as well as a hepatic artery as well. At this edge, you'll also see the liver, the IVC, and the SMV. And you will also see like the vertebral body and the left kidney as well. So this is another classical potential view that you could be presented to label this as well. So you potentially could have that. It's one of the things I want you guys to like take away from this, and do some more work in your own time as well. Looking at our rupture image, what would you say about this image? Like, if they say, what are the abnormal findings? We talked about it a little bit earlier about a mural thrombus. So you can actually see the mural thrombus. But then, of course, there's a wall rupture there as well. And then let's look at another view of a triple A, which has got a mural thrombus in there in the lumen. And then you can actually see evidence of rupture there as well. You might not see a wall break right there, but then you actually see a large collection of fluid, and which is obviously blood, and that will be an acute retroperitoneal bleed, which is what it looks like on a transabdominal ultrasound. So potentially interpreting an abnormal image is obviously fair game in the exam. The exam also says you can be assessed on hemodynamic assessment in the fellowship exam. So part of the hemodynamic assessment of the fellowship exam is whatever protocol you might use to actually assess a patient. You might not get specifically asked or explain to us what rush means, but you might be asked to say, what would you do in features of, for example, what would you look for in a patient in shock and in a patient with unsort of differentiated hypotension? What would you actually do? Well, in reality, what you really do is a rush protocol in all these patients. You want to look for all the sources that could provide you with an answer. And the rush protocol is an easy one to remember because it has an actual like a proper mnemonic, and the mnemonic stands for high map. There's also an extended version, but we're just going to go with the basic version. If you had an exam question, 70-year-old male comes in, syncope, persistent hypotension, post-fluid bolus, list 5 rush components or rapid, or list 5 ultrasound components and one key finding in each that you look for in a patient who's shocked. Well, this is a good mnemonic to use to answer your question. So you write high map, you write, well, heart. I'll look at severe LV dysfunction, pericardial tamponade. I'll look for a hyperdynamic LV to tell me about a distributive shock, for example. Look for signs of a PE, such as RV strain, McConnell sign. Looking at the IVC and to see whether or not there's an element of volume responsiveness. And obviously, you need to use this as part of your full assessment. You can't go with it in isolation. And then the Morrison's pouch, looking for free fluid in the abdomen. And of course, looking at the aorta for AAA rupture, as well as a dissection, and looking for pulmonary findings, which is obviously going to be things like pneumothorax, hemothorax, something that could explain the hypotension. So I think this is fair game for the exam. A question like this in a table format with systems as well as findings, which I think is something that I want you guys to take away and think about, because if you can spend 30 seconds less or even a minute less in answering a question like this, that means you gain extra time for the rest of your questions. For, as you know, the fellowship exam, time is crucial. Like the people who don't do well in fellowship SAQs generally are people who don't finish on time and are always rushing. So it makes it quite challenging. So if you can answer some basic ultrasound questions pretty quickly, you're well on the way to achieving a good score. Let's talk about cardiac tamponade. This is more of a learning section, but also a section for the fellowship exam as well. Don't worry about the content of this data. They can actually summarize that really well. List ultrasound signs suggestive of cardiac tamponade. Obviously, pericardial effusion, the presence and the large size of it, and the contents of it would make it more likely. And other main features of findings, and I want to keep it simple, is right ventricular diastolic collapse and right atrial systolic collapse. That's important to remember, and keep it simple. Right systolic collapse and right ventricular diastolic collapse. There are some nuances to that. For example, the right atrial systolic collapse must persist more than 1/3 of the cardiac cycle. That's one of the actual features of it. It's also pretty sensitive and highly specific. The right ventricular diastolic collapse is pretty specific, but not really that sensitive. The issue with this is with the right ventricle, sometimes if a patient has pre-existing pulmonary hypertension, that could delay the presence of those findings. Now, the IVC is another one that we always look at whether or not it's distended, and especially you want to see if there's any respiratory variation. If there's a distended IVC with no respiratory variation, that's usually a finding that's highly associated with a tamponade physiology. There are two specific features for on findings for Doppler ultrasound, which are particular ones that you could put down in the fellowship exam. And these are things that I want you guys to understand, but you may not be the person who performs these examinations, but there's still things that are important to know about. Our transmitral variation of a Doppler assessment, which I'll cover next, as well as a trans-tricuspid velocity variation as well. And these are things that change with respiration. So I'll explain that next, what I mean. So have a look at this image. This summarizes some of the features. We talked about the right, like systolic collapse. That's one of the earliest signs. We talked about the plethoric IVC with less than 50% collapse. And obviously that's plethoric, larger than 2.1 centimeters. These numbers are important. So please imprint these numbers in your head. There's a big difference between saying dilated IVC in the fellowship exam versus saying a better candidate would write a plethoric IVC with less than 50% collapse and greater than 2.1 centimeters. That's a better fellowship answer compared to just someone writing dilated IVC. Right ventricular diastolic collapse, as well as the mitral valve, tricuspid valve flow variations. Let's talk about the flow variations. Ignore the numbers on the right because the numbers are not entirely like suggestive or accurate, but I want you to look at the trace. So what's the the inflow variation? So essentially what you're looking at is the physiology of the heart in normal heart physiology versus tamponade. So in the normal heart, what you actually see is when you actually take a deep breath in, you get a normal effect, which is an increased return to the heart. When you have an increased return to the right heart, there's obviously going to be more flow across the tricuspid valve. So when you have an increased return to the heart and you have a higher tricuspid valve flow, that often means there's more blood flowing to through the tricuspid valve. Now, if you imagine the heart sits in the pericardium is a tight sac. The heart can't actually bulge out anymore. The pericardium restricts the heart. So the only way for the right ventricle to expand is for the intraventricular septum to actually push into your left ventricle. So when that expands, automatically the mitral valve velocities and the amount of blood flow drops across the valve itself. And that's kind of the key thing I want you to take out. So basically, this is a term called ventricular interdependence, and that's a normal part of your heart physiology. So increased tricuspid flow when you breathe in, which means the tricuspid velocity increases. So you can see on the bottom trace here on the tricuspid flow, the actual velocity is higher. The peak is higher on inspiration, and then the expiration, it drops. Now, the same thing happens on the mitral valve side. It's the opposite. In mitral valve, because you're breathing in and the ventricle is bulging into the left ventricle, obviously the velocity is less. So on the mitral valve side, the inspiration peak velocity is less. And when you actually breathe out, the actual velocity rises. Now, in a normal heart, the numbers are a lot more like normal. So in the mitral valve, less than 15% is considered normal. In the tricuspid, less than 25% is considered normal in terms of variation between the heights of the peaks of those. Now, in a tamponade situation, because the heart's surrounded by an effusion, there's even less of a potential for it to actually expand. So what is really happening is the right ventricle, the left side of the heart, the right side of the heart and the left side of the heart are both competing against each other, which essentially means it exaggerates the difference between the peaks. And that's all I want you to take away from this, is to say that the actual velocity variation is exaggerated. So what that really means is that in a tricuspid flow like variation, you actually get greater than 40% variation is considered tamponade, whereas on the mitral or the left ventricle side, greater than 25% is considered like tamponade. So that's a tamponade physiology. So it's important. I know it's a lot of information. It's not enough to be able to sort of get that kind of understanding in just one slide. But I want you guys to actually take it away, have a look for some resources, which I'll put in the chat later to be able to understand that. Mohan had a question. Sorry.
Sorry, Abra, I was just monitoring the chat. There's a question about TAPSI, usefulness of TAPSI for tamponade and PE.
Yeah, I'll cover that as well with PE, as I'll cover that at the end. It's a good question. It's not something I think that's a great one to put down for fellowship exam purposes, but that's the short answer. But I'll cover that as well. Essentially, TAPSI is an element of really how well your right ventricle is functioning. In the normal heart, your tricuspid annular plane, which is the plane where the tricuspid valve sits, is going to actually bounce and move a lot. And that's like a feature of a heart that's functioning well. And obviously, if there's a lot of constriction, there's a lot of an element of raised right ventricular pressures, you're actually not going to be able to like move as much. So the TAPSI will be different, and that affects that feature. But I don't think that's a good fellowship exam answer later. But I'll explain that later. Let's cover PE with that in mind. A question for PE would be, would tell us about the sonographic signs seen with a massive PE. And PE is really prime time. So I want the fellowship candidates to take away with that because the new guidelines, the international guidelines for PE have just come out. And they rely quite heavily on getting the echocardiogram done for these patients to make some decision making. That expertise with the echoes, like now being, I think the respiratory teams are actually trying to gain that expertise. So it's important to be able to communicate with them along the same language. And you probably, as an ED physician or an ED registrar, will have a better knowledge of this than the respiratory registrar would in many centers. So I think this is a good one where we can take the lead on this. The 5 sonographic signs with massive PE that I would suggest to write, well, 5 are there, but there's also a 6th one, would be the McConnell sign. A McConnell sign essentially means that you have a akinesia of your right ventricular free wall, of the middle of the wall, but the actual apex of the right ventricle is hyperkinetic or preserved. So when you look at it on an echo, the apex is actually moving a lot, but the actual ventricular free wall is not moving very much at all as well. So that's pretty specific, and that's a very popular sign that everyone remembers because the name given to it, McConnell. The D-shaped LV septal flattening is the one that the registrars learn first because that's the easiest one to spot and see, where there's a flattening of the interventricular septum. It looks like a D, essentially, when you look on a parasternal short axis. This is also the D shape that the radiologist comments on a CTPA when they do a contrast study for a PE. That's what it looks like when they actually look at it. Essentially, you look at the interventricular septum, and the LV just looks like a D shape, and that's like a sign of RV pressure. It can also have a volume overload as well. Right ventricular dilatation is important to remember, especially if it's approaching 1:1. As you know, the RV is normally about 60% of the LV size. So if it's approaching close to the same size as the LV, then that's like something that you have to consider could be a part of a massive PE as well. In saying that someone with already pre-existing pulmonary hypertension can also present with that like feature as well. So it's important to know what their previous history is. A dilated IVC with the lack of respiratory collapse also indicates elevated right-sided heart pressures. And a clot in transit, you can't really beat that. A clot in transit, a mobile thrombus in the IVC or the right atrium or near the pulmonary artery, it essentially confirms the diagnosis and is probably the best sign you can see in someone. But unfortunately, some of these signs are seen in people who are actually in cardiac arrest. So that's like a totally different talk altogether regarding thrombolysis in those patients. Another common one that is coming into vogue now is a sign called the 60-60 sign. Now, yeah, as a person who trains registrars for ultrasound and things, I try not to introduce a lot of complexity, and already there's a lot of complexity in your work, but ultrasound is gaining a bit more of that. And this sign is another one of those. Now, will you ever do or perform this sign, which is called the 66 sign using Dopplers? I don't think so. I don't do that in my clinical practice because I just don't have the time. You can't actually get the expertise down and spend enough time with the patients to actually demonstrate it. But essentially, it looks at pulmonary acceleration time, and it also looks at calculation of pulmonary artery systolic pressures. This sign is meant to be highly specific for acute PE versus a chronic core pulmonale. And if you can remember anything, just remember the numbers need to be less than 60 because that's why it says 60-60. So a PAT less than 60 milliseconds and a pressure less than 60 millimeters of mercury, highly specific for acute PE. We'll explain that later in the future talk as to what those means. They're very complex to explain, but essentially it means that your heart, your RV, your heart is struggling to actually pump out blood, your right ventricle, and that'll obviously, if you're pushing blood through against a PE, you're going to have a higher acceleration, longer acceleration time through the pulmonary valve, as well as the pressures are going to be also like different as well. So that's really what you need to remember. Let's look at a couple of basic things that you might be more associated with. Let's look at acute cholecystitis. A question could be, for example, 46-year-old with right upper pain and fever, ultrasound findings. What findings would you, what 5 or 6 findings would you list to support a diagnosis of acute cholecystitis? There are some surprising ones here that people might not realize. There are non-specific features that everybody knows. As you become a registrar, you'll understand about features like gallbladder wall thickening greater than 4 millimeters and pericolic cystic fluid. Now, those are actually non-specific features because you see them in a lot of other conditions as well. But the primary or specific features are dilated gallbladder greater than 4 centimeters transverse or greater than 8 centimeters in length. A sign called a tensile fundus sign is pretty specific if you see it. What that really means is when you look at the gallbladder is so dilated, it actually pushes against the abdominal wall, and the abdominal wall indents. You can also see this on a CT scan as well, where the actual dilated gallbladder actually indents the abdominal wall. That's called a tensile fundus sign. Impacted stone of the gallbladder neck or cystic duct, wall hyperemia on color Doppler, which means essentially when you pop your color Doppler on, it's a really, really enhanced sort of vascularity of the actual gallbladder wall. And a sonographic Murphy's on probe pressure, which is a very common thing that we look for on the ultrasound report. That's pretty specific as well. Signs of gangrene you might see will be like a disconnection of the actual wall, obviously a rupture. You might see evidence of some gas. You will see some echogenic pericholecystic fat and some interrupted gallbladder wall as well. So the sonographic Murphy's has a poor sensitivity, so it's important to remember that as well. So some of the features of that we talked about. I'll put this picture up because this is a picture of the first ultrasound scan that I ever did as a registrar. I did 2 scans as a junior reg back in as a PGY4 back in 2012. I did an ultrasound of an abdomen in a lady, which is this picture here, and I did a lung ultrasound in an acute pulmonary edema, and that's how I fell in love with ultrasound. This is the picture that I took for this lady, which allowed me to actually refer to the surgeons and get her admitted and expedited much faster than doing actually formal ultrasound. So you can see some of the features I talked about. You can see a gallbladder with a thickened gallbladder wall. It's actually markedly thickened. It's not just like 5 millimeters. It's really massively thickened. You can also see sludge and gallstones as well. And you can see pericholecystic fluid, and she was probe tender as well. So a lot of different features there, some specific, some non-specific. One important thing about gallbladder wall measurement, it needs to be done adjacent to the liver. You can't actually do it away from the liver wall. It's not really very accurate. You actually need to measure the actual gallbladder wall adjacent to where it abuts the liver itself. So that's one of the features. So I would encourage all the registrars to pick up the probe and examine anyone that they see with right upper quadrant pain, because you might actually pick up something that will clinch the diagnosis for you. If you find something on ultrasound, remember, you always got to act on it. If you don't find something, then it doesn't really help you very much. Again, another feature that I mentioned with the measurement of the gallbladder wall, this one's almost 9 millimeters. And you can see the measurements being done against the liver wall, against the liver margin as well. So that's very important. In this feature, you've got sludge and you've got stones. Acute appendicitis. So acute appendicitis is an important one. Acute appendicitis is something we always say that appendicitis is a clinical diagnosis, and in appendicitis, like you actually want to be able to confirm a lot of different features that will support the diagnosis. And a question, for example, 24 years old male with right lower quadrant abdomen fever, list 6 signs that could suggest a diagnosis of appendicitis. The most common one that's mentioned in the literature is a target or bullseye sign. Essentially, Lowe's transverse view shows bowel wall thickening, which is it really looks at the submucosa and the muscularis and it just looks like a target. Wall thickening greater than 3 millimeters with the color Doppler showing increased vascularity. That's also very specific. And sometimes you can have no flow at all if the actual appendix is necrotic. And in wall stratification is another one. If you can actually see all the different walls and it's preserved, you can often see that it's like you can say it's non-necrotic, but a loss of stratification indicates necrosis. So that's one of the features that you can sort of say, yeah, most certainly I can't see what the walls are made of at all. And you can't actually like tell that as well. And that's one of the main features as well. Now, if it's the classical one that the sonographers will always write is a non-compressible blind ending tube. So a good fellowship answer for getting a fellowship mark would be aperistaltic, fluid-filled, greater than 6 millimeter outer diameter, non-compressible blind ending tube. So that's kind of like you need to be able to elucidate that in a sentence. If you see an appendiculate that with the posterior shadowing, that also can indicate some evidence of an appendicitis as a possible sort of reason. And periappendiceal changes like reactive lymphadenopathy, periappendiceal free fluid, especially if it's ruptured, and hyperechoic sort of fat around that region as well as sometimes sonographers will comment on that. So these are all little features of acute appendicitis. Some of the photos that I'll show through that as well. This is on that image of an appendix that you can see. In this area here, you can actually see a little bit of normal appendix, which is proximal. And then as it goes down further, you can actually see a dilated like distal appendix, which is quite large. And you can actually see that's like quite a long blind ending fluid structure as well with some measurements. And you look at like contents of an appendix, you can actually see a little bit of debris as well in the fluid level. And of course, a dilated appendix with a blind end. So a lot of these features are features that you might look for. This is just for interest's sake, but don't expect you guys to go out and do appendix ultrasounds. As we all know, appendicitis is very often not picked up on an ultrasound, and a negative ultrasound is not helpful at all. And so usually ultrasound is not something you would reach for in an appendicitis as a clinical diagnosis, but it's still part of your investigation setup, and you might get referrals from people who have done it and positive findings. So it's important to know what they are, and it's important to be able to understand what you're looking at as well. So in terms of just a final slide, I've put in a lot of these questions as SAQs and MCQ documents. This is the link that I'll pop in the chat now. I'll just actually put that in the chat group now as well, so you guys can just directly click on it and access the documents. And just to also say that if you guys are looking for any fellowship SAQ preparation resources, I'd recommend checking out some podcasts on fellowship exam topics with the artofelmergency.com. And that's, I think, I often get people asking me in terms of how things are going with that and things. So I think people are obviously listening. We get about 200 so odd downloads every month. And that's something that I would recommend you guys check out. But yeah, the POCUS SAQ and MCQ questions are on that first link that I've put up. Those links, you can download them, they're PDF files. Happy for you to share them, do whatever you want, and things. In terms of the question that someone had about the TAPSE, the TAPSE essentially assesses right ventricular longitudinal movement during systole. So basically how far the tricuspid annulus moves towards the apex when you actually have systole. So the main problem in tamponade is impaired diastolic filling. It's not really a primary right ventricular systolic failure. So that is one of those things where in TAPSE, it might actually be normal or preserved, especially in early tamponade. So you can't really rely on TAPSE as one of your features to put down for tamponade, for example. So that's why I've not put it up. And only something that you might see the TAPSE is reduced less than 17 millimeters if you actually see it in late tamponade. So that's not really something you rely on. If you see it in late tamponade, you'll have all the other features that that are described in the slide already. So in the exam, I don't want you to put down TAPSE as an answer for tamponade. I want you to put down all of those other ones that we actually talked about and RV dysfunction and things like that. So if there's any other questions, I'm happy to take them. I think Mohan, I don't know, your hand is up. I understand Anthony
What?
has talked about the fellowship exam textbook, but yeah, it's not something that I would use. And I know that the exam always says that you need to link things back to your fellowship resources. I'm going to rely more on the ultrasound fellowship modules to see whether or not I'll have to check whether they've mentioned TAPSE there in one of the modules or not in the advanced modules. But my understanding is that, yeah, it's not something you would actually, it may be reduced, but not something I'd put down as an exam answer. If there's any questions, happy for you to email me. I will put down my email address in the chat box now. If you guys are keen, we have an ultrasound fellowship special skills rotation at Peninsula University Hospital, which are 3-month and 6-month rotations. Happy for you guys to get in touch with us. If you're interested, we would like to target a combination of junior and senior trainees. We've got some really advanced practitioners who are teaching those rotations. And feel free to apply. Thanks, everyone. We'll end a little bit early. That way, if you have any questions, you can send us. Thank you. Thanks, everyone, to all of my core DMTs as well. Thank you.
Thanks, Abra.
Thanks, everyone.
Well
Cheers.
done.
Cheers. Bye, everyone.
Bye, everyone. Thanks.
Maybe with the DMTs can stay on and we can